Hi, I'm Dr. Logan. I'm a radiation oncologist, and thanks for joining me. I'm going to be talking briefly about uh, breast cancers, which are called T3. And I'm going to look at the question of when can we leave out radiation treatment after a person's had a mastectomy for a T3 breast cancer. And T3 breast cancers are bigger cancers, at least 5 centimeters in size, but they aren't deeply fixed into the skin and they aren't deeply fixed into the structures of the chest wall. And we're also going to be looking at the instance where, at the time of diagnosis, there are no involved lymph nodes. There's no lymph nodes that are abnormal to be felt. There's no abnormal lymph nodes on ultrasound. And if any node biopsies have been done, they're all clear. And we're going to talk about the situation where the initial treatment is drug treatment, so-called neoadjuvant treatment. And the cornerstone of that is typically chemotherapy. But depending on the features of the cancer, there can be immunotherapy or targeted therapy if the cancer is HER2 positive. There are some cancers which are hormone receptor positive that may have endocrine therapies as the leading treatment. But the idea is that there are drug treatments that occur and then surgery is carried out. And when that mastectomy is done, we're looking at the situation of where there's no invasive cancer to be found in the breast or in the lymph nodes that are removed. And that's the setting where we look at the question, should radiation be given or can we avoid radiation treatment? And that mastectomy surgery may be a standard mastectomy or it might be skin and nipple sparing and an immediate reconstruction may have been done. And if we were to take an example where the pathologist looks at the tissue and says, yes, no, there's no cancer in the lymph nodes, and in the breast itself, we've sectioned through it, we might see a tumor bed, some fibrous tissue where the invasive cancer once was, but nothing more. And sometimes the pathologist will say there's no invasive cancer, but gosh, there is non-invasive cancer or in situ cancer. If we think a bit about that, in that little diagram, the pink purple circular rim would be, say, the wall of a duct, and that black material inside would be cancer cells inside the duct. That makes it the in situ or non invasive cancer. And in a way, those cells inside the ducts are hidden away from the drug treatments that are carried by the bloodstream. That treatment interacts well with the invasive cancer that's infiltrating the tissues, but in a way that material inside the ducts is, as I say, in a separate place. So it's not unusual to see all invasive cancer gone, but some invasive cancer, some non-invasive cancer left behind. So it turns out that the non-invasive cancer is not usually a problem if a mastectomy has been done, unless the non-invasive cancer is very extensive and is either right on or very, very close to multiple margins, and especially if it's what's called a high nuclear grade. But if the non-invasive cancer has been well cleared with the mastectomy, even a skin-sparing mastectomy, it's generally not a problem. So it's the response of the cancer to that neoadjuvant treatment before surgery that helps us decide whether we need to use any radiation for the T3 cancer. We're looking at the question of how likely is it that there would be still microscopic cancer cells left behind, either in the chest wall or in the lymph nodes that haven't been removed, or in little tissue fluid channels tracking through the chest wall. And as you might imagine, if the invasive cancer is all gone, that is, that the pathologist can't see any, then it's going to be very unlikely that there's going to be microscopic cancer lingering in these areas. So if we were to compare, if the chance is for some reason high enough, you add radiation treatment to the chest wall, lymph nodes, and the whole region. But if the original cancer wasn't locally advanced, if there's no invasive cancer left in the breast, if there was never any sign of it in the nodes, and if there is any non-invasive cancer, it's well clear of margins, then it's going to be very unlikely that there's cancer lingering in those little microscopic locations. And so the answer, should radiation be given, is no. And to summarize, when we think about radiation after mastectomy, if we're looking at a lower risk situation, we don't treat. And if we're looking at a higher risk situation, then we. Our current guidelines say that for T3N0 cancers, the choice for radiation after mastectomy depends on the individual consultation with the oncologist and the degree of pathologic response. So if you've been fortunate to have a complete clearance of your invasive cancer, and if there's any non-invasive cancer left, it's nicely clear of the margins, that typically you could completely forego any extra radiation. And that, of course, enables you to avoid any of the side effects of radiation. Thanks very much for your attention. And if you've looked at this in anticipation of seeing me for a consult visit, I look forward to meeting you. Thanks again.